I'm looking at program science through this lens, as I've been asked to do, maximizing impact and investment returns. And throughout my talk, I use these questions to shape my presentation. Why worry? Do we have proven interventions? What could we achieve with full implementation, but what's actual implementation like? And how can we do better? Just a bit of background. Despite the successes, HIV is still by far the fastest growing cause of global disease burden in the last 20 years, according to Chris Murray's study, moving from 26th to 5th position. So it's not over. HIV and malaria are by far the two leading causes of disease burden in sub-Saharan Africa, as we see here. And if we look at countries in Eastern and Southern Africa, it's by far the single biggest cause of disease burden. So there's every reason to remain concerned. I'm sure many of us remember this Economist cover, and we've heard a lot about the end of AIDS. And as a backdrop to my talk today, I'm probing this question. And it's certainly true that national level incidence declines, modeled declines, are really encouraging. But when we actually measure subnational incidence, it's a bit more worrying. And we're working on a comprehensive study at this at the moment. Here's the good news. Estimated national HIV incidence has fallen by over 20% in the last decade, and all the indications are that the new UNAIDS report at the end of the year will show this trend deepening. We have 39 countries, including 23 African countries, with a decline of 25% or more. And this graph shows you the increasing, the stable, the decreasing countries, with the countries embedded in the graphs. So far, so good. But when we look at all the trials and the subnational data, the picture's more worrying. In the VOICE trial, women under 25 in South Africa had a 9% incidence. In CAPRISA, KwaZulu-Natal, over 7%. In our own work in Lesotho, over 6%. And if we look at key populations in Asia, we see incidence still exceeding 5%. So there's some good news, but the empirical data are still extremely worrying. So let's look at the question. Can we invest more smartly for greater impact? I think that this question requires a program science lens, as Jamie outlined, looking at understanding transmission dynamics, using proven interventions for the right people in the right place at the right time. And we're all familiar with this distinction, but I think it still holds good. And that's the distinction between concentrated and generalized epidemics, which we can define operationally. And epidemics are concentrated if protecting our key populations would prevent a wider epidemic. And they're generalized if epidemics would be sustained even if we protected key populations. And they're mixed if we could close one transmission source and still see an epidemic from the other transmission source. And using this framework globally, what's striking is most of the world faces concentrated epidemics, with the exception of sub-Saharan Africa, and in particular Eastern and Southern Africa. The epidemics of West and Central Africa are harder to characterize, and they really do pivot on what the contribution of sex work is. And I return to this question. Look at this example in Indonesia, the world's fourth largest country, the largest Muslim country, an archipelago of several thousand islands. Its HIV epidemic is equally diverse. In Jakarta, a mega city of 15 million people, we see a concentrated epidemic dominated by drug use and men having sex with men. In Papua, formerly Irian Jaya, a Melanesian Pacific community, we see a generalized epidemic resembling sub-Saharan Africa's. So even within countries, we can see both concentrated and generalized epidemics. Here's a nice piece of work from Cross River State in Nigeria. And using older transmission models, it looked as if we had generalized epidemics with some broad categories, and only 20% of transmission was attributable to sex work. But when we sharpen the model, what we actually see is two important things. First, sex work still appears to account for about 50% of transmission. But secondly, for anyone who knows and works in Africa, the category of transactional sex leaps out as an important category. So better models, better understanding, better basis for allocating resources and effort. And here's a nice example from Sharmista, who's sitting in the audience, showing how in India, just looking at the tables can mislead us. Here, what actually seems to be the case is the lowest prevalence epidemics are the most generalized, and the highest prevalence are the most concentrated. Counterintuitive, but Sharmista walks us through the logic that these are really imported epidemics from migrant workers in transmission nodes, particularly in Bombay and Maharashtra. Why should we worry about concentrated epidemics? Well, first of all, let's just remind ourselves how much higher the risk factors are. They're 13-fold for sex workers and men having sex with men, and they're at least 20-fold for injecting drug users. So let's turn to sex workers and ask ourselves these questions. Well, this graph really shows us how we should worry. The red dots represent general population prevalence, the black dots sex worker prevalence. We can see they're markedly higher in nearly all cases. The good news is, in concentrated sex work epidemics, we actually know what to do in the real world at scale. And we've actually stopped many epidemics through these 6 core interventions, really beautifully exemplified in the work that Jamie and colleagues have led in India, perhaps the most successful prevention response globally. But it's not just in India. We've seen in Africa, Burkina Faso, particularly the second city of Boba Dioulasso, striking declines in sex worker transmission, followed by declines in general population transmission. So targeted interventions for sex workers work and have an impact. But the bad news is when we look at real-world implementation, which is limited. The bottom line here is if we look at all the countries reporting globally to UNAIDS on sex worker programs, 75% either report very low coverage or don't report. 91% of funding is international. And services for male sex workers and transgenders are virtually non-existent. And here's a really nice example from Benin, small country bordering Nigeria. Sex workers, according to Michel Allery of Laval University in Quebec's research, constitute about 75% of transmission in Cotonou, but receive less than 0.5% of the national prevention budget. And in India, we have a really nice study from Jamie and colleagues looking at the comparative cost effectiveness of extending the existing targeted interventions, which have reduced transmission by at least 2/3 and perhaps 75%, versus mounting a test and treat program. And the bottom line is, as you would expect in India, which has such successful behavioral programs, test and treat offers marginal improvements at much greater cost, on average 10-fold greater than sustaining the existing programs. We're going to look at this in other contexts, such as South Africa, but the data is still sobering. And I'd just like to highlight a key point, and that is, in India, sex work is unambiguous. In Africa, it's extraordinarily varied, diverse, and polymathic. And this illustrates it beautifully. If we look at both formal sex workers who self-acknowledge in red and informal, non-self-identifying sex workers in pink, we see HIV prevalence can be higher in informal groups, such as bar waitresses or mobile traders. We also see what a range of occupations are linked to sex work. And the bottom line is we have good programs for formal self-acknowledged professional sex workers. It's much harder to reach sex workers who don't even self-identify. And so the 5 things I think we can do even better in sex work programs are summarized here. First, the better epi analysis that I've already spoken about. Second, a greater investment in standard operating procedure, defined, socially franchised, quality-assured formal programs, exemplified by India. A much greater focus on real-time data for continuous improvement. A much greater focus on high transmission geographic areas. And we really need to develop proven interventions for hotspots and informal sex workers, which I don't think we yet have. Let's turn now to concentrated MSM epidemics and use the same questions to guide us. This clearly shows why we should be concerned. Again, with the red dots representing general population transmission and the black dots MSM transmission, we see how much higher rates are among men having sex with men. And I think the real world picture is even more disturbing. Despite a few developed country successes, including Canada, very few developing countries have demonstrably reduced MSM transmission. Now, we know PrEP reduced transmission by at least 40% among MSM in Bangkok, but we also know at the moment we can't even get basic information and awareness to men having sex with men. So getting tablets daily, or at least however frequently we need to as the science improves, is a challenge. And we really don't know how to reach hidden MSM, to reduce stigma, and to deliver at scale in much of the developing world. So this area remains extremely vexed. And when we look at the global reporting, we see the fruits of this challenge. Over 70% of countries don't report or report very low coverage. 90% of all MSM programs are internationally, not domestically financed. And 19 out of the 21 low and middle income countries reporting were reliant wholly on external financing. And that's very worrying as we see a move towards greater domestic responsibility in financing. And just look at this. This is one of the most sobering graphs I present. This is global coverage of MSM programs. But just look, in Africa, 12% of MSM are reached by the most basic prevention programs. In the Caribbean, it's only 25%. So we don't even have basic awareness coverage. Let's turn to the equally challenging area of injecting drug use and use these questions. The same graph, red for the general population, black for IDUs, illustrates the even greater disparity here, with 20-fold and up to 60-fold higher ratios among injecting drug users. When we look at whether we have proven interventions, we do. We actually have 3 well-proven interventions: needle syringe programs, opioid substitution therapy, and to a lesser extent, based principally on some ambiguous data from Vancouver's Lower East Side, ART. And if we look here at the evidence, if we look at NSPs, we've got the famous 99 city study showing HIV 20% lower in cities with NSPs and 10% higher in cities without. If we look at OST, which is by some criteria the most widely evaluated public health intervention of all, we've got great evidence from RCTs, from observational studies, from the Cochrane Systematic Review, from the Amsterdam cohort, and from the recent MacArthur et al. BMJ systematic meta-analysis. The same graph here, even more disturbing. If we look at NSP coverage in terms of the number of needles and syringes distributed per IDU, we find here that 86% either don't report or report very low coverage indeed. And this graph is as striking as the MSM one. If we look at IDU have access to the most basic services, needle syringes, opioids, and ART, 90% have no access to needle syringes, 92% have no access to opioid substitution therapy, and 85% have no access to ART. Let's turn to generalized epidemics and pose the same questions. This graph, to me, underscores the fundamental difference with everything we've discussed so far. The bottom line here, in Swaziland and the hyperepidemics of Southern Africa, casual sex is widespread, commercial sex is rare. This graph is almost the inverse of what we would see in India and much of Asia. And the epidemic challenge facing us is, how do we effect behavior change? How do we prevent transmission in the general population, not just with key populations? And this is what generalized epidemics look like if we look at this really nice example from KwaZulu-Natal. But the bottom line is shown at the bottom. 76% of transmission appears to be in the general heterosexual population, in people who don't fit any of the traditional risk groups, and for whom our interventions are, as I will show, weaker. Why worry? This one graph says it all. This is a national, door-to-door household prevalence and incidence survey. The SHIMS, 18,000 people in Swaziland. It's staggering. Over half of all women in Swaziland aged 30 to 34 are HIV positive. So more than every second woman you meet in the street in this age is HIV positive. And men aged 35 to 39 aren't far behind. So, the vexed question, do we have proven approaches? This is a familiar slide. It's an update of all the evidence we have from randomized controlled trials with HIV incidence endpoints. And if we look at them, the bottom line is, effectively, we've got 3 categories of plausibly supported interventions. We've got male circumcision, which is unambiguously the clearest. 3 different trials in very different contexts and countries with an identical protective effect of at least 60%. We've got treatment for prevention in different forms, including PrEP. And we've got a less decisive but still important body of World Bank studies showing that financial incentives, cash transfers to young men and particularly young women, appear to reduce transmission by 30 to 50%, which may be the only thing we have to offer young women. Let's look at each of these interventions and the opportunities they present. We know that voluntary male medical circumcision is at least 60% effective in clinical trials. But the good news, including good news from a Kenya study that the University of Manitoba are heavily involved in, is the real-life population level effect appears even greater, as we'd expect, and it's sustained. So we're seeing incidence declines of between 67 and 76% over 4 to 6 years in Eastern and Southern Africa. The other good news is it's an extraordinarily cost-effective intervention, as you would expect from one simple, irreversible, lifelong protective procedure. And 80% implementation of circumcision would avert 3.5 million, or almost 1/4 of new infections in 14 priority countries in Eastern and Southern Africa. It's very cost-effective. If we start young, it's $1,000 per HIV infection averted, which, as we'll see later, is extremely cost-effective. And it amortizes or pays for itself in just 7 years, and very few public health interventions pay for themselves in such a short period. But the bad news, actual implementation. At the halfway mark of a global male circumcision initiative, only 3 million out of a targeted 21 million procedures have been performed. That's less than 14% of the targeted and 11% of the total. So again, the immense disparity between ideal and actual implementation. Let's turn to the topic of the day, TASP, treatment as prevention. We know that the clinical level efficacy under ideal conditions is at least 96 and actually closer to 100% because the famous Malawi 052 trial had a misclassified transmission episode. But there's several reasons to believe the real-world effectiveness may be lower. In KwaZulu-Natal, in a careful study, we saw a decline of 1/3 with 30 to 40% coverage. But more interestingly, that appeared to be the saturation level for the effect, for reasons we don't yet fully understand. In China, in a very real-world context, we saw a 26% decline among discordant couples who were infected by transfusion or sexual transmission, but no decline among IDU infected, which raises questions of adherence and retention. There was a study in Uganda that found no difference. And we've got papers by my colleague David Wilson at the University of New South Wales showing that HIV continues to rise, even in Australia's almost wholly treated MSM cohort. And we have similar studies from London and many areas in the West. And then finally, back to Swaziland. With 85% of its population on treatment at CD4 350 or less, Swaziland still has a measured national incidence of 2.5% on top of an adult prevalence of 26%. And my point is, it's hard to see how Swaziland's incidence could be any higher, even in the absence of any programs after 3 decades and a 26% prevalence and the presumptive elimination of susceptibles. To answer this question of real-world effectiveness, there are 4 studies in the field, and some of them are very elegant. The difficulty is we're going to wait 5 to 8 years for a result. So we have to ask some important questions in the absence of the real-world effectiveness data. And this is the challenge before us. by many criteria, PEPFAR is one of the 2 or 3 most successful public health interventions globally in history, ranking right up with vaccination as an extraordinary achievement. And through PEPFAR, the largest global health initiative in history, through a tremendous infusion of resources and personnel and commitment, we've reached almost 10 million people on treatment today. But to go to CD4 500, the new WHO criteria, would mean treating 26 million. And to go to test and treat would mean treating 32 million. So that's akin to doing 2.5 to 3 more PEPFARs. And that's an immense challenge. And we're all familiar with the treatment cascade. How many people who are HIV positive and who are actually on treatment and virally suppressed? And even in the US, by some criteria, only 28% are, according to the CDC CROI study, virally suppressed. And that reflects perhaps the fact that although treatment's free in the US, public health access isn't necessarily free or easy. And it's true, the European treatment cascades look better. But when we look at the West African treatment cascade, based on work by our partners from the University of Montpellier and ANRS, only 10% are virally suppressed. Retention is an immense problem. This should be very worrying. In Malawi, after 5 years, only 60% of people on treatment are retained. And that's despite the largest infusion of finances and technical resources from international agencies in the HIV response. In Indonesia, a large middle-income country, only 50% are retained. And when we look at viral load, here's a really good study from South Africa, from Cape Town, which has good and bad news. The good news is that people on ART are much less likely to be infectious. The bad news is a third still are. We know about the problems of drug resistance, but this study should give us pause. It shows that after just 3 years, 20% of the population have acquired HIV drug resistance. And this graph makes the same point, showing drug resistance nodes in many parts of the world. Here's a really careful study by the Africa Center in Matuba in KwaZulu-Natal, looking at the cost effectiveness of different options, of treatment for prevention, of treatment for treatment, and of male circumcision. It's complex, but the bottom line is all were cost effective at the WHO rule of 3 times per capita GDP. But that's a pretty inclusive definition of cost effectiveness. The bad news is, in fact, high treatment for treatment's sake plus male circumcision coverage produced similar incidence reductions to treatment for prevention. And it did so for $5 billion less. And the bottom line is increased male circumcision averted an infection for about $1,000, outperforming treatment for treatment, which averted an infection for $7,000, and TASP, which averted an infection for $8,500. And the reasons are obvious. Male circumcision is more effective because its cost is 1/9 and it accrues once versus over a lifetime. And I think the key conclusion of the study, which I personally agree with, as we've only enrolled half of those needing treatment at CD350, in other words, the sicker, increasing treatment should proceed by disease stage rather than automatically enrolling everybody with high CD4 levels. Financial incentives. 3 World Bank studies I briefly want to talk about, each of them showing that giving cash transfers reduced HIV transmission. And in Tanzania, people offered up to $60 each annually to stay STI-free, had a 25% lower STI prevalence. In Malawi, even more interestingly, girls and parents who were offered up to $15 monthly just to stay in school had a 60% lower HIV prevalence in a randomized controlled trial. And that effect held whether they stayed in school or not, suggesting that the cash and the agency the cash conferred rather than the schooling was the direct effect. And in Lesotho, as economists will do, trying to expand the incentive to lotteries, which you can expand more cheaply, offering people an opportunity to win $50 or $100 every 4 months if they stayed STI and HIV free, had a 25% lower HIV incidence, which was 33% lower among girls and 31% lower in the high lottery reward arm. So this is extremely interesting and challenging. And here's a summary of each of the studies in Tanzania, Malawi, and Lesotho. And here's a summary of the effect sizes in each case. But I think the most important point to make is it may sound far-fetched to pay young people to remain STI or HIV-free. But the beauty is this is one intervention which can pay for itself across the development budget. Cash transfers to girls keep young girls in school. They get better educated, which has tremendous intergenerational benefits when they become mothers and parents. It reduces early marriages. It reduces other STIs. It reduces teenage pregnancy. And it reduces HIV. So we have an intervention which has a host of positive developmental outcomes, a host of positive intergenerational outcomes. An intervention which can be paid for from education, from social welfare, from community development budgets. But I'm not sure we're at the point where we should be recommending this on a large scale. There are questions to answer. Is the evidence robust enough? Are the incentives scalable, affordable, and durable? What happens when they're withdrawn? We don't yet know for sure. And where do we go next with this evidence? We have a big symposium at the ICASA AIDS in Africa meeting in December, where we're looking at this question with senior policymakers. But I don't think we're yet at the point where we think this should be a definite go on a large scale. There's a big focus on geographic targeting and hotspots, and Jamie touched on this with the Great Nigeria work he's doing. And UNAIDS's report this year, the World AIDS Day report, will focus on this precise question. And Mark Dybel of the Global Fund has said publicly he thinks better targeting can bring us much closer to eliminating HIV. So a lot hinges on this question. So let's just go through the evidence. We know from Indonesia that half of the epidemic was historically in Papua, which has only 2% of the population. We know in the Philippines that 43% of the whole epidemic is MSM in Metro Manila, and 73% is MSM in just 3 cities, Calamba across the bay from Manila and Cebu, the major southern maritime center. And one of the big reasons India succeeded is 75% of its epidemic was in just 4 high-burden but also high-capacity southern and western states. And very discreetly, India put its money into these states, which many countries have failed to do. In Nigeria, we have the world's second largest and by far the world's most diverse epidemic, with every recombinant strain you could envisage. And 70% of Nigeria's epidemic is in just 13 of its 37 states and territories. And key populations constitute just 4% of the population and about half of the transmission. So we can target intelligently. Nice work from Jamie. We know how concentrated injecting drug use is in Pakistan, principally in the megacity of Karachi, but also in several other cities, principally in Punjab. And there's really exciting work from Frank Tanzer and his team at the KwaZulu-Natal Africa Center in Hlabiso Matubatuba. And here's a typical township. The exciting thing is if we map serotransmission in KwaZulu-Natal, we see a lot of geographic clustering. I'll return to analyze this more. And when we actually look at HIV concentrations per square kilometer, this 3-dimensional graph really shows us how geographically concentrated transmission is. But we don't know yet what underlies these data, because we know that many rural areas in South Africa have principally old people, as young people have left for migrant work. So we need to understand socially what this means. Does it mean more than our previous insight that informal settlements in South Africa were real nodes of transmission? And here's a lovely study by Laith Abu Radad and his colleagues looking at spatial clustering in the GHS in sub-Saharan Africa. And he was able to do this study where we had HIV coordinates and GPS data. So it's interesting and unusual. Here's the bottom line. Tremendous spatial variation with valleys of high prevalence, dams which block transmission, and islands of either very high or very low transmission. 14 lived in high prevalence clusters and 16% in low prevalence clusters. That's not that exciting. It's not different to what we'd expect in a relatively normal distribution. But this continental average masks some important subnational variation. And the bottom line here is we see a lot more clustering in concentrated epidemics, like Senegal, Burkina Faso, Sierra Leone, and Ethiopia. And we see a lot less clustering in high prevalence countries, with none in Swazi, very little in Zambia and Lesotho. And we do see dams of high and low prevalence, and male circumcision seems to be the principal building block of these dams. So where do we stand? Here's a summary. I think, first of all, there's obviously a major opportunity for greater geographic targeting in large, diverse countries, but we already knew that. There's a lot of opportunity for hotspot targeting, particularly in more concentrated epidemics. There's a real opportunity for what I call detargeting, taking money out of low prevalence or zero prevalence areas. Ethiopia's large southern Rift Valley, for example, had no HIV infections in the first EDHS, but it continued to receive the same share of the budget as high prevalence regions such as Addis or Gambela. But I think we need a rigorous test, not just advocacy, of the feasibility and utility of geographic and hotspot targeting. And for me, the key question is this an 80-20 rule? Can we stop 80% of the transmission by targeting 20% of the areas? Or is it a line call, a 55-45 rule? Much less utility. And I think that's what this will hinge on. Let's turn briefly in my final sections to financing. We have seen international financing stagnate, and we have a significant resource gap, according to UNAIDS. And we have seen the global financial crisis has hit overall development assistance. It fell by 2% in 2011 and a further 4% in 2012. And that was the first fall in a generation. Look at South Africa. This is the Minister Pravin Gordhan's own budget presentation from June. South Africa's AIDS budget grew 500% in a decade to almost $2 billion, the second largest globally after the US. And that's an impressive achievement. But the really scary part is in the finance minister's projections for 2015. By then, HIV will be nearly 40% of the whole health budget. And bear in mind, South Africa has a whole host of other health challenges, from TB to NCDs. South Africa also has a structural budget deficit. There have only 2 years where it's had a budget surplus. So it's not as if the money can easily be found. And here's another worry. This is a word cloud based on the high-level panel report on the post-MDGs. The bottom line is the MDG world has changed beyond our reckoning. 4 of the 8 previous MDGs were health-related. Look today at how small health is in the post-MDG word cloud, which is dominated by poverty alleviation, partnership, and growth. It's a very different agenda, partly because the perception is the heavy work has been done. The perception is we've moved from diseases of scarcity and infection, communicable diseases, to diseases of affluence, to non-communicable diseases. And that's a tough perception to fight. So let me summarize. I think we faced, at best, a flat financing landscape, and we do face the competing priorities that I touched upon in the word cloud. With the existing implementation and projected rate of expansion, we are likely to prevent less than half of the new infections over the next decade. But with full implementation, we could prevent a lot more. But moving from actual to full implementation means a completely different world. It means a world that's not focused on advocacy, but that's focused on program science, real epidemic understanding, a real focus on the implementation pillar in the middle, the science of delivery, applying the same rigor to management and delivery that we do to the virus itself. And finally, I personally agree with Bill Gates and others that before we can talk of ending AIDS, we need more and better tools. We've had the tools to end TB, to end syphilis and chlamydia for decades. We all know the data, and we haven't. Thank you very much indeed.